Yeah, it does work. I tested it. Yeah. Good morning. Does work? It works. Okay. I see that people are still coming in, but we might kick off because it's 9 o'clock. Welcome to the second day of this lovely conference, we had a wonderful time yesterday, and I'm really looking forward to all the talks and everything else today. My name is Jane McDougall. I'm a consultant gynecologist and subspecialist in reproductive medicine in Cambridge in the UK. I'm absolutely delighted to be here, and I'm going to pass across to my co-chair for this session.
Hello, my name is Justyna Łuczak and I'm a pediatric surgeon, so another specialty in this conference, and I am especially interested in ovarian lesions. I got a PhD from this topic exactly, and this is what I do every day. My pediatric center is a referral center for ovarian lesions in our region in Poland. I'm from Poland. Thank you.
Right. Thank you. So welcome to the session on ovarian imaging and lesions. And first of all, I'd like to introduce Dr. Paulina Pavicevic.
Okay.
Yeah, thank you very much. Who's a pediatric radiologist here in Belgrade. Thank you very much.
Thank you for introducing me. Hello, good morning to everybody. It is a great honor for me to be here today with you and to share with you my presentation about imaging of ovarian masses. As you heard, I'm a pediatric radiologist. I work at the University Children's Hospital in Belgrade. And thanks, Zoran, for inviting me today. So I will start because we don't have enough time. As you know, ovarian neoplasms are the heterogeneous group of lesions that can be divided according to their cell of origin into three groups: germ cell, sex cord, stromal, and epithelial. And differentiating benign from malignant lesions are reaching the correct diagnosis in a timely manner is crucial to reduce morbidity and mortality. And this review, I will try to discuss the spectrum of ovarian neoplasms in the pediatric population and describe, first of all, their imaging, then a little bit clinical and histologic characteristics. So what are these features that radiologists should be familiar with the variable sonographic CT and MRI findings of ovarian neoplasms? So you all know that ultrasonography is the modality of choice for the initial evaluation of ovarian masses because we know all its wide availability, real-time dynamic nature, and lack of ionizing radiation and sedation risks. So we use transabdominal ultrasound approach and using the bladder as an acoustic window, so it's more appropriate in most children and adolescents than the more detailed endovaginal examination. So when we are thinking about another second diagnostic modality, so MR or CT, so we know that MR has higher soft tissue resolution. It's the preferred second-line diagnostic modality. And why? Because it can give us further characterization and local regional staging of malignant tumors because MRI can accurately assess adjust organs and the pelvic side wall for involvement. On the other side, limitation of MRI is because we need sedation for children under the age of 6 or 7, and on the other side, the examination, duration of the examination is too long, 30 to 45 minutes. On the other side, we have CT because there is limitation is big radiation dose, although the examination is much shorter. So I have also to say that we can use also PET CT in some malignancies, for example, like in dysgerminoma and so on, for looking for metastasis. So although they are not so rare, because there is a 2.6 incidence per 100,000 girls, and most lucky. Most pediatric ovarian tumors are benign, so however 10 to 30% are malignant. So they're about 1 to 3% of all childhood malignancies. And you know the clinical presentation, they are usually present with lower abdominal pain or a palpable mass, and the presentation can be acute when complicated by torsion, rupture, hemorrhage, or very rarely intestinal urinary obstruction. So what about diagnosis? So we have to be familiar on one side with demographic data, laboratory results, and of course imaging features. But very important are tumor markers, as you know. So when we are performing, we as radiologists, any MRI, CT, or ultrasound, we immediately call the oncologist, hemato-oncologists at our clinic to ask how are the tumor markers. So we have to be aware that there are a lot of tumor markers you can see here on the table too. So on the other side is, for example, elevated serum levels, alpha-fetoprotein or beta-HCG are highly indicative of malignancy on one side, but we have to be aware that elevated are only in 50% of malignant lesions. So these are the imaging features that are often associated with malignancy, which included mass. The size, it's larger than 10 centimeters. But there are some studies have suggested using a cutoff of 8 centimeters instead of 10. So also the presence of solid components, and addition, presence of tumor enhancement and or hypervascularity is also associated with malignancy. So you can see this on color Doppler, but also on MRI and CT. So ASIT has also been reported to be a sign as malignancy. But in one study of 150 pediatric patients, ovarian masses with no solid components, which size was less than 10 centimeters, and no positive tumor markers were rarely malignant, so the probability was less than 1%. So the germ cell tumor is a group of tumors which the classification means there are teratoma, mature and immature, dyskerminoma, York cell tumor, embryonic carcinoma, and so on. On the one side, mature cystic teratoma, also known as dermal cysts, are the most common germ cell tumors and the most common benign childhood ovarian tumors. On the other side, these carcinomas are the most common malignant ovarian germ cell tumors. So we know all that teratomas can be mature and immature according to the degree of cellular differentiation of their components. So what are the imaging features? On ultrasound, it can show variable appearance depending on their contents, which can be a mix of fluid, sebum, fat, hair, on calcification. And most commonly, they present as a unilocular cyst with hyperechoic nodule originating from the wall and protruding into the lumen, so-called Rokitansky nodule. So we see here a typical cystic appearance of a mature teratoma with hyperechoic nodule protruding into the cystic part of the mass. But we have also another imaging modalities to confirm our ultrasound, and this is MRI. So on MRI, the interlesional fat shows a high signal intensity on T1 and T2 weighted imaging, which suppresses on fat suppressed sequences. So I can show it here. So we have here correlation between ultrasound. So you see this hyperechoic nodule, Rokitansky, but on MRI, I told you before, we have this fat suppression sequences. It means when the tumor is bright and when we've suppressed the fat, it loses the signal. So you can see the difference here. So it means this is fat. So the diagnosis is very easy. We have here also void signals. Here, hypointensity, it means this must be calcification. We have here also another case of mature teratoma, just to show you how important is the fat suppression sequence. So you see here very bright tumor protruding into the cystic part of the big, huge tumor, and a loss of signal, and with fat suppression, it means again it is fat. So here, void signals, calcification, no post-contrast enhancement, it must be mature teratoma. What about immature teratoma? They, on imaging, tend to be larger. 12 to 25, they mature and demonstrate a predominantly solid component with few and much smaller scattered foci on the face calcification. Here's another case with this fat suppression MRI T2 sequences. So you see there is no loss of signal, so there is cystic solid part. On T1 there is a foci hemorrhagic, this hyperintensity, and on post-contrast there was enhancing, so it must be solid part. On DVI, diffusion weighted imaging showed negative words, so it must be immature teratoma. But we have this here also very interesting case from one 4-year-old girl who came to our clinic with pain and constipation, referred with diagnosis. They told us it could be pelvic abscess. They tried also to drainage through perianal fistula, but when we performed ultrasound, we saw this huge predominantly solid mass with this scattered calcification and also revascularization. So we were very surprised. So we thought it could be some precoccygeal, maybe teratoma. But when we performed MRI, we were surprised again, but not very good surprise, because there was some interspinal propagation of the tumor with hemorrhage, with post-contrast enhancement, and you can see here in the sagittal view. And definitely the diagnosis was surgery, immature teratoma. So although these arise, this sacrococcygeal in the sacrococcygeal area, type 4 is in particular may be mistaken for ovarian germ cell tumor due to its complete intrapelvic growth pattern. So upon prenatal suspicion of CCT on ultrasound, fetal MRI should be obtained for further evaluation of the tumor extent associated malformations. So what about this geminoma? Are the malignant tumors equivalent to seminoma in males? And they constitute 30% of germ cell tumors and occur bilaterally in 15%. Although non-specific, so again, tumor markers are positive, LDH. Levels there may be used as adjunct for diagnosis. Imaging ultrasound shows, unfortunately, non-specific vascular solid ovarian mass without specific distinguishing features. So this is the problem. And this geminoma appears as a solid lobulated mass with fibrovascular septa that show low signal intensity on T1 and T2 and enhance post-contrast. So we have here another case of this geminoma, which was confirmed after surgery. This was an 11-year-old girl with firm palpable abdominal mass and elevated serum markers, tumor markers. And we have here ultrasound transfer and longitudinal plane. So you see this solid mass with cystic areas and also vascularization. So it was really almost 12 centimeters. So you see the similarity here between ultrasound and MRI. This is a cystic part, and it was post-contrast enhancement. We saw also secondary deposition in front of the left kidney, and finally it was this carcinoma. So there are some imaging features that can help you to distinguish between benign and malignant lesion. What about Yolk sac tumors? They are the malignant germ cell tumors. They may be seen as a separate entity, and it's the second most common subtype of malignant germ cell tumor and accounts for about 20%, and alpha-fetoproteins commonly elevated. So on MRI, the imaging features I may not specific. There are some signs like bright dot sign may be seen in the form of enhancing foci attributed to the dilated blood vessels within these hypervascular tumors, or maybe capsular tears. So there's a case of one 10-year-old girl with an ovarian Yolk cell tumor, but on MRI we couldn't see any specific findings which I mentioned before. So we didn't know what it was, but histology confirmed Yolk sac tumor. Series from the literature, one CT of Yolk sac tumor with elevated alpha-fetoprotein. So you can see here fat calcification and post-contrast enhancement. Sex chorostomal tumors, the two most common in pediatric age group is granulosa cell tumor and Sertoli Leydig cell tumor. This class of tumor is known for hormonal secretion resulting in endocrine features. So we had this case of juvenile granulosa cell tumor, which is the most malignant tumor in this group, and mostly affecting prepubertal girls. So imaging, they vary widely on imaging, from cystic to solid, and often contain hemorrhagic and fibrotic changes. So ultrasound and CT usually reveal a multicystic mass with solid components and septation. So a characteristic may be sometimes sponge-like appearance in T2, but it's not very usual. So here's another case of juvenile granulosa cell tumor in 3-year-old girl who presented also in emergency room with acute onset with abdominal pain. So you see here on T2 with and without fat suppression, there was no change of signal. So it is cystic, it is solid, there is post-contrast enhancement and vascularization, and DVI show osteorestriction. So it was malignant juvenile granulosa cell tumor. What about sertoli-Leydig cell tumors? They have a low malignant potential even when large and account for less than 0.5% of all ovarian masses. And sometimes patients may present with virilization and hirsutism due to excess androgen secretion by the tumor. Imaging the tumors are also confined to the ovary and show non-specific appearance again, ranging from cystic to solid. So ultrasound maybe can show hypoechoic lesion, and MRI demonstrate a mixture of hypo and hyperintensity signal on T2 and delayed post-contrast enhancement. So this is one case of 14-year-old girl presenting with virilization with sertoli-Leydig cells. So you see here in ultrasound dominant cystic, but there is also solid part. On CT, unfortunately, it was CT post-contrast enhancement, so histopathology revealed. So this is work for histopathologists and surgeons. What about epithelial tumors? So this benign lesion includes serous, mucinous, and mixed cystadenomas, and are the most common ovarian epithelial tumors in children. And imaging of serous cystadenoma may appear as a usually unilocular or multilocular cystic mass with homogeneous components and thin septations. On the other hand, mucinous cystadenoma is typically multilocular with heterogeneous internal components and thin septations. So you have here a case in MRI with serous cystadenoma. You see it's very large, but it's homogeneous, hyperintense, with no loss of signal, and the right ovary is preserved, so it is very important, of course. And of T1, there was no post-contrast enhancement, so it means it must be serous cystadenoma. What about mucinous cystadenoma? So this is a case of 14-year-old girl with large abdominal mass, which MRI is showing a large multilocular cystic mass with no post-contrast enhancing on T1 images. So you can see here the septa are not enhancing, so it must be mucinous cystadenoma. So I will tell something just short about spectrum of which situation in which pathology can be mimics of ovarian tumors. These are ovarian cysts. You're very familiar with endometrioma, paraovarian cyst, and peritoneal inclusion cyst. So you know everything ovarian cyst, but for us, radiologists, we have to know that cysts larger than 7 centimeters are difficult to fully evaluate using ultrasound. Then we usually perform MRI. But MRI is then recommended. So this is one just case of simple cyst of the right ovarian. So you see the intensity is not changed. There is no post-contrast enhancement. So there are also hemorrhagic ovarian cysts, you know, this with hyperintensity. We don't need to perform ultrasound if the surgeon believes us that this is hemorrhagic cyst. Sometimes we have problems to make them believe us. So what about endometriomas? They usually show the thick-walled cyst with homogeneous ground glass. And I told before, this was a case of our colleague. This, of course, not adolescent, not a child, but just to show you that there is no change signal in T1, post-contrast and native, and T2, it is still hyper-intense with no restriction on diffusion. So the histopathology also, our colleague told us, revealed it was endometrioma. We don't see it so very often. So what we know everything about adnexal torsion, but some, however, about the vascularity, when you have a typical case, it's very easy, but we have to be aware the presence of flow and Doppler ultrasound does not exclude torsion and should not delay surgical intervention if clinical suspicion is high, as ovary have dual arterial supply. So we have here this typical ovarian torsion with the big ovary, with the cystic part, with no Doppler, and with this, we call it in radiology Whirlpool sign, this twisted ovarian vessels. So it was, of course, torsion. But we have this also very specific case when, for example, isolated fallopian tube torsion started in this girl. She was 17 years old and she was visiting a lot of hospitals with still pain. Nobody could tell her what was wrong. On ultrasound, there was just a cyst. It was called like para-ovarian cyst, but ovarian, but were very good vascularizated. So at the end, the surgeon wanted us to perform MRI. They were right, because there was a twisted ovarian tube on the left, and she was operated. So it was a case of isolated fallopian tube torsion. It can happen also. So there are also other neoplastic measures, but I will tell in conclusion that a variety of ovarian lesions occur in the pediatric population. Maximizing survival while preserving fertility takes precedence of this young patient. So imaging plays a crucial role in diagnosis, disease staging, and treatment planning. So again, ultrasound remains the imaging modality of choice for initial evaluation, and MRI is useful adjunct for further characterization lesions. So although imaging findings may overlap, awareness of typical and atypical imaging features of the common lesion in pediatric patients, as well as the tumor's clinical presentation and tumor marker profiles, ensures the delivery of optimal care. Thank you.
Thank you very much. Some lovely pictures, thank you. And a really helpful overview. So our next speaker is, I think what we're going to do actually is we'll take questions at the end in view of timing and everything else. So Dr. Susan Odongo is going to give our next talk entitled Catch Me Early. And she's a WCPAG fellow, and we all met her yesterday because she won a scholarship. So congratulations for that. Thank you very much.
Good morning, everyone. Good morning. Yeah, where I come from, you have to respond. So my name is Susan Diana Kini Adongo. I'm currently a clinical fellow at HCTM, UKM, Kuala Lumpur, Malaysia. I was born, bred, raised, and educated in Kenya. And if somebody had told me last year on a day like today, next year, 19th of May 2023, you will be in a country in Southeast Europe called Belgrade, presenting to wonderful people like yourselves, I would have said, wake up, you're dreaming. And that's why I'm privileged and honored to be before you today. So my presentation today was born from a systematic review that a special interest group, certain members of FIGIC, have come together to do on ovarian lesions in the pediatric and adolescent gynecology population. My team, specifically, together with my fellow fellows and Dr. Evelyn Roos, Professor Anya Amelia, and Professor Zura is not here with us today. We were doing the common and uncommon clinical presentations of ovarian lesions in this population so that we aim for timely diagnosis and appropriate management and reduce the complication rate in this group. Hence the title, Catch Me Early. Wow, how do we move forward? Okay, so I have nothing to disclose. This is the outline for my presentation. So as I've just mentioned, that ovarian lesions, as we know, are the most common abdominal masses in the pediatric population. And we cannot extrapolate the presentation in one age group to a different age group. And we have noticed that sometimes the symptoms and signs are often missed, causing delay in management and complications. That is why, as I said, we came together and identified and synthesized existing literature on what are the common and uncommon clinical presentations of ovarian lesions. We actually stratified the population, the PAG population, into three groups: neonates, premenarche, and adolescent age group. As you can see, we used the PRISMA 2020 guidelines and came up with specific keywords to encompass all the ovarian lesions that can occur in this age group, from ovarian cysts, ovarian torsion, and ovarian tumors, both benign and malignant. And we were very specific on the inclusion and exclusion criteria, keeping to the specific age groups. So these were some of the results. You can see most of our articles were derived from the PubMed database. And if you can see, just with the population distribution in terms of the clinical presentation, neonates had the lowest prevalence of ovarian cysts at 6% of ovarian lesions, followed by the premenarche group at 37%, and the adolescent group was the majority at about 56%. So what are some of the commonest symptoms we found? We found that in neonates, 43% of them actually presented with abdominal masses, but surprisingly so, actually a bigger percentage had no symptom on presentation and were just discovered on routine care. Less common symptoms that were seen were symptoms of precocity like breast budding, pubic hair growth, hydronephrosis, and abdominal distension. 33% of neonates actually presented with ovarian torsion as a presentation. So therefore, we also need to have a high index of suspicion in this group. For the premenarche group, the commonest symptom was 48% of girls who presented with abdominal pain, commonest sign of an abdominal mass, and features of precocity like breast enlargement. Less commonly, we had those who presented with vaginal bleeding and constitutional symptoms like nausea, fever, vomiting, urinary retention, and constipation. Those that presented with ovarian torsion as a presentation were at 24% in the premenarche group. The adolescent group, most common symptom, and surprisingly so, was abdominal pain in 66% of the patients. Less commonly, those who presented primarily with abnormal uterine bleeding as a symptom were at about 0.9% with ascites and hydronephrosis. We also discovered that 81% of those in the adolescent group mostly presented with benign tumors. So as we collate all these results in our systematic review, we came to realize that neonates uncommonly present with symptoms of ovarian lesions. Therefore, we must have a high index of suspicion needed when we encounter a neonate with an abdominal mass. And those discovered antenatally, because there were those that were discovered on routine antenatal care, should have routine ultrasound follow-up postnatally to reduce the incidence of ovarian torsion, as we saw that 33% of neonates presented with ovarian torsion. In the premenarche group, those presenting with symptoms of precocious puberty should be evaluated for functional ovarian masses, as we discovered that many of them are largely misdiagnosed, causing delayed treatment, torsion, making ovarian sparing surgery difficult. And for the adolescent group, those who present with menstrual irregularities or abnormal uterine bleeding with abdominal pain and elevated tumor markers should also be assessed for ovarian masses. In conclusion, timely diagnosis of ovarian masses in children will lead to early and appropriate management with fewer complications and fertility-sparing surgery. Thank you very much.
Thank you very much for a really clear presentation, really helpful, and kept wonderfully to time. Okay, so our next speaker is Dr. Kennedy, who comes from Switzerland and is a gynecologist there.
Pediatric surgeon.
Pediatric. Oh, I
exactly.
I do apologise. Okay. Although we work really closely, don't we, with our paediatric surgeons and
Exactly.
our gynecologists. So it's really important in this subject, actually. Okay, thank you very much.
So good morning, everyone. I'm very happy and honored to be able to talk to you about how to save the ovary from a surgical perspective today. So a brief overview. I'm going to speak about the surgical management of ovarian torsion and neonatal ovarian cysts. It is shocking to see that in this study, in about 2/3 of cases of ovarian lesions that were mostly benign, an ovarectomy was performed, especially if the surgery was done by a surgeon and not a gynecologist. You all know that an ovarectomy can have serious consequences for the girl or adolescent, and my goal is in the following minutes to show you how to save the ovaries in any possible way. Let's speak about ovarian torsion first. Ovarian torsion is the reason for abdominal complaints in about 1 to 3% of cases, and the age peak is around 14.5 years. So in order to save the ovaries in the setting of torsion, we need a correct and timely diagnosis, and also a correct ovary-sparing therapy. Let's start with the diagnosis. This study is from a group from Cincinnati in 2018. They created a composite score for aiding in diagnosing ovarian torsion. They looked at over 300 patients and specific clinical and radiological features that predict the risk for ovarian torsion. So on the left side you can see the score, and on the right side you can see the interpretation of the score. This might be helpful in a case where you're not sure about ovarian torsion or not. So finally, we have made the diagnosis, so let's go to the management. And here I want to have your opinion briefly. You can just raise your hand. What would you do? You find this ovary well perfused during surgery. Detours or remove the ovary? Who is for detorsing? And who is for removing? Okay, that was pretty clear. So let's go to the next one. Here you can see on ultrasound preoperatively, you find a complex hyperechogenic cyst, and there is no time for further workup. So what would you do? Detours? Remove? Okay, you're absolutely correct. And then the final image, the image of a typical blue and black ovary that was obviously torsed. What would you do? Detours? Remove the ovary? Okay, I can tell you that if I asked my fellow surgeons, there might be some hesitance, because let's say if this was a testicle, we would probably, many of us would vote for removal. So let's go to the literature. This is a Japanese cross-sectional study. They looked at 24,000 women and their menopausal state. And they showed that unilateral oophorectomy carries a risk for premature ovarian failure and early menopause. This, again, of course, increases the risk for cardiovascular complications and osteoporosis. And here's a systematic review that looks at the management and the outcomes of ovarian torsion. So are there any risks in detorsing the ovary and leaving it intra-abdominally? Some people are scared of missing occult malignancy. The malignancy rate in this population is very low. So if you look at the literature, there is no evidence to remove an ovary for the fear of occult malignancy. As you can see on this image, it's also not always very easy to diagnose malignancy just according to the macroscopic appearance. So it is recommended to do your workup and then do a second staging surgery if there is fear for malignancy. Are there any benefits of only detorsing the ovary? So we saw the blue and black ovary before, and there is no correlation of outcome and the gross appearance of a blue and black ovary. There are studies that show that in up to 70% of patients that had this presentation at torsion, there are still visible follicles on post-operative ultrasound. This is probably mainly due to ovarian torsion causing venous congestion with preserved arterial flow. And then again, once we've detorsed the ovary, is there any indication to perform a pexy of the ovary? The risk of recurrent torsion is said to be about 5 to 18%, and risk factors being anatomic predisposition and the absence of an ovarian mass. There are multiple surgical methods that are described, such as plication of the adnexal ligaments or a fixation at the lateral abdominal wall. Probably this means that there is not one primary surgical intervention that is more beneficial. Overall, when looking at the literature, there is no clear evidence for pexy of the ovary in the setting of a first torsion. Here is one of our patients. She presented with a torsion of the right ovary, which was detorsed, but a couple of weeks later she came again, and she actually had a torsion of the left ovary. So the left ovary was detorsed as well, but you can see that the right side had completely atrophied. So the surgeon decided to perform a PEXI to the lateral abdominal wall, and fortunately the patient has been asymptomatic since. So let's go to our second subject, the prenatal and neonatal ovarian cysts. These cysts occur during the phases of hormonal stimulation, meaning during pregnancy and the so-called mini-puberty phase. You can see the hormonal pattern during these phases on this image here. This is a systematic review on the management and outcome of fetal ovarian cysts. Overall, these cysts show a very high spontaneous resolution rate, but the resolution likelihood is less likely if the cysts are complex or are larger than 4 centimeters. If there is a change in ultrasound pattern, that could be a sign of ovarian loss. As for management, ultrasound-guided aspiration of the cyst is a possibility, which of course reduces the risk for torsion, however, carries a very high recurrence risk. So as in any prenatal intervention, the risks and benefits need to be weighed carefully. Here is one of our patients with a complex neonatal ovarian cyst that we have followed up for months. You can see that the central part has consolidated. Since the patient hasn't had any symptoms and no signs of malignancy, we have not performed any surgery on her. Another case, a 7-centimeter simple cyst at birth that was aspirated by ultrasound guidance. You can see here the cyst has collapsed nicely, and you can even see some adjacent follicles in the surrounding ovarian tissue. Overall, there are still no clear guidelines on how to correctly manage these neonatal and prenatal ovarian cysts. Long-term studies show that probably conservative management is advisable even in the setting of a complex cyst. But I still have many more open questions. What is the surgical indication? Maybe the occurrence of symptoms, possible malignancy, or failure of cyst regression. How long should we follow up these patients? Should we check tumor markers? And what about the residual function of these ovaries? So a lot to work on in the future. But I'm already at the end, and as a take-home message, I just want to let you know that you shouldn't overreact and don't overreact. Thank you very much.
Thank you very much. Another lovely, clear talk with great slides. Thank you. So I'm going to hand over to my co-chair.
And the next presentation will be presented by Dr. Bojana Tomic, who is a trainee gynecologist here in Belgrade. The normal ovarian tissue and mature teratomas.
Thank you. Good morning to everyone. I'm very grateful to the organizing committee for giving me the opportunity to be with you today and talk about the normal ovarian tissue and mature teratomas. I have nothing to disclose. The motto of this presentation is simple. When you want something to do, you find a way. And when you don't want to, you find an excuse. Pursuing this motto in the treatment of ovarian benign lesions, we are determined to preserve the ovaries whenever is possible. And what is the way of doing that? Our knowledge regarding the ovarian mature teratomas is, as the most common ovarian pathology, is principally based on many retrospective studies that are very useful but also very confusing in practice. Newest IOTA study from 2022 relieved 4 new ultrasonographic signs for mature ovarian teratomas. And our adult gynecology teachers learn us to be proud when reporting them during the evaluation of adnexal masses. And it seems a lot like a great competition with pathologists. But what about patients? It's not stated how many ovaries are preserved using these ultrasonographic signs, like it's not a matter of importance. Today, the young gynecologists are in prison with this education based on retrospective studies. We are trapped in a crowd between the knowledge of gynecologists, surgeons, radiologists, and pathologists. And using a stripping technique, as you can see, we can easily preserve the ovary from mature teratoma. In this case, the whole ovary with the tumor was sent to pathology analysis. and unfortunately, preoperative evaluations and reports did not consist of research for normal ovarian tissue. Surgeons, they feel safe when they perform ovariectomy. It's a very big trap. You can see the corpus luteum in the normal ovarian tissue, and it's obviously that ovariectomy in this young patient was not a good choice. But thanks to the enthusiasm and pursuing the motto from the beginning, we got out of the prison, and I'm sure you can easily recognize the presence of normal ovarian tissue that surrounds the tumor, even in a huge masses, during the laparoscopy and laparotomy. And on ultrasonography, you can see the presence of normal ovarian tissue, known as ovarian Christian sign, and no matter how it's stretched and thin, it is present, and it should always be respected. A great Canadian study shows that a retrospective evaluation of ovarian Christian sign using ultrasonographic photos is not so accurate and useful, and that prospective investigations about the importance of ovarian Christian sign need to be conducted. And we found out that even radiologists admired the ovary more than gynecologists by drawing the normal ovarian tissue in their classification or RAD system. But unfortunately, they did not start to include the ovarian Christian sign in their reports, neither on ultrasonography nor on magnetic resonance. And in our prospective study that took place from January 2006 to November 2022, ovarian mature teratomas were confirmed in 109 surgically treated young patients under 19 years old. And our focus, preoperative focus, was not on describing the tumor, but on the presence of normal ovarian tissue, the ovarian Christian sign, as the most important ultrasonographic sign. The presence of normal ovarian tissue was confirmed preoperatively in all of 94 patients, uncomplicated by torsion, using transabdominal, transvaginal, and transrectal probe equally successful. In all of them, the tumor was removed successfully and the ovaries were preserved during the surgery. And 15 patients had ovarian teratoma complicated by torsion. And instead of ovarian Christian sign, we reported ultrasound sign of ovarian edema in all of them. And 9 ovaries were preserved in our study, and 6 of them, unfortunately, underwent annexectomy, including the presented ovary, mainly because of diagnostic delay. And regardless of the surgical approach in the treatment of ovarian mature teratomas, the first and the main goal should be ovarian preservation. Laparoscopy, of course, should be performed whenever is possible. And in our study, 84 laparoscopies and 25 laparotomies were performed. And French philosopher Henri Bergson said, the eye sees only what the mind is prepared to comprehend. So when will we all start to see and report the presence of normal ovarian tissue during the evaluation of adnexal masses? It will become significant only when we truly have the intention to preserve the ovary from the tumor. And when our aim is ovarian preservation, then reporting of ovarian Christian sign during ultrasonography is a must. And we all should be educated about it. Thank you for your attention.
Thank you very much for this excellent presentation. And our last speaker is Dr. Anis Serovac from Bosnia with the presentation about the role of tumor markers in preoperative assessment. The floor is yours.
Good morning. At first, I want to say thank you and congratulate Dr. Stankovic for excellent organization of this World Congress and for give opportunity to young colleagues. The topic of my presentation is the role of tumor markers in preoperative assessment of adnexal masses in pediatric and adolescent gynecology. There are many questions, but a few answers. Benign or malignant adnexal masses? Which tumor marker for which type of ovarian tumor? Influence of torsion, endometriosis, inflammation of adnexal masses on tumor markers values. Difference between pediatric and adolescents. Monitoring the effect of surgery and chemotherapy. Studies demonstrate the variability in tumor marker testing during the workup of pediatric ovarian neoplasms. Although the role of tumor markers may vary based on suspect or confirmed pathology, many studies show that alpha-fetoprotein lactodehydrogenase cancer antigen 125, cancer antigen 99, beta human chorionic gonadotropin, carcinal embryonic antigen, inhibin A and B may be useful to risk stratify pediatric patients with an ovarian neoplasm and help guide appropriate surgical management. While malignancy ultimately requires histopathological analysis, the high sensitivity, specificity, positive and negative predictive values of the various tumor markers suggest that they are both valuable and accurate for preoperative risk satisfaction when evaluated as panel of tumor markers. Any elevated tumor marker alone is a significant risk factor for malignancy. In this table, we can see tumor markers and tumor types. We can see that many tumor markers are elevated in malignant germ cell tumors, but some are specific, like cancer antigen 125 for epithelial ovarian cancer, estradiol and testosterone for sex cord stromal tumor, granulosa cell tumor, sartorial Leydig cell tumors, beta human chorionic gonadotropin for choriocarcinoma, immature teratome, embryonal carcinoma, mixed germ cell tumor. The aim of this study is to examine the importance of tumor markers in diagnosis of adnexal masses in pediatric and adolescent gynecology. Relevant studies published over the last 20 years were identified by PubMed Medline search using different combination of following search terms like tumor markers, adnexal masses, and pediatric and adolescent gynecology. Additional papers were identified by reviewing reference list of relevant publications. Non-English publications were excluded. A systematic approach to study selection was not implemented. Instead, data were extracted based on their relevance of the topic. By searching the literature, we found out 5 studies that meet our criteria, 15 studies that were not original studies and represented a review of the literature, and previously published studies were excluded. Literature review consisted of 5 remarkable articles in period from 1996 to 2016 and included 796 pediatric and adolescent patients with neoplastic ovarian masses and increase of tumor markers. Out of the total number of patients, 127 or 16% were malignant ovarian tumors. In this table, we can see a percentage of positive tumor markers in malignant adnexal masses. We can see that cancer antigen 125 was positive in 38 to 100%. The lowest percentage of positiveness have inhibin A and B. Lawrence et al. In their study found sensitivity and specificity for tumor markers, and we can see that different tumor markers have different sensitivity and specificity, like cancer antigen 125 have sensitivity 59% and specificity 81%. Alpha-fetoprotein have relatively low sensitivity but high specificity. Lactodehydrogenase have a high sensitivity but low specificity. Lawrence et al. Also reported proportion of cohorts that received tumor marker testing. We can see that alpha-fetoprotein was highly examined tumor marker in 94%, and cancer antigen 99 very low testing in 13%. Spinelli et al. Reported proportion of tumor marker testing in 88%. And we can say that elevated values of tumor markers in malignant adnexal masses range from 54 to 100%. In conclusion, we can say that tumor markers are important in preoperative evaluation and differential diagnosis of adnexal masses in pediatric and adolescent gynecology, but also in making a decision about radicality or fertility-sparing surgical procedure. When malignancy is suspected, a panel of tumor markers is necessary because there is no single tumor marker that is sufficiently reliable. And international collaborations and prospective studies are necessary to determine the reliable predictive value of tumor markers in the preoperative evaluation of adnexal masses. Thank you for your attention.
Thank you very much. I think that now is the time for discussion. So, are there any questions to the presentations that were presented? The audience have any questions? Okay, please. Do we have a
Do we have a
microphone?
roving mic here? Okay, thanks. So if you could just introduce yourself and just say where you're from and then your question.
Good morning. We're from Bulgaria. My name is Dr. Petrakieva, Natalia. And I wanted to ask you, when we see this gross picture of this blue-black torsed ovary, and we know that we have an ovarian mass that's behind the torsion. When we do the surgery and see this picture, we decide to preserve the ovary and detorse it. Do you do a cystectomy? Do you extract the ovarian mass on the first surgery, or do you do a second stage one? So because it's edematous and so on. And in the post-operative period, do you use antithrombotic prophylaxis? In which protocol? And if you do a second stage surgery, how do you manage the time?
So lots of questions. Perhaps we could ask the people, all the speakers, to come up and answer. Maybe
Kennedy,
for our pediatric surgeon. You're nodding, so yeah. Do you want to answer that question? Yeah.
Okay. This mic is on? Okay. Thanks for the question. I would probably only detorse the ovary without trying to remove the lesion because it's going to be difficult, and if there is malignancy behind the lesion, you don't want to have a risk of spillage or anything. Then you can take your time to do the workup and proceed with the second stage surgery. As for timing, probably I would do it as soon as possible, but not earlier than maybe 2 weeks to let the edema go back. We are a pure children's hospital, so we don't use antithrombotic prophylaxis a lot, except if the patient is really old, like almost an adult, and maybe overweight, but otherwise we would not.
You often find actually that if you try and remove the cyst at the time of the detorsion, you'll get lots of bleeding and problems, and you end up having to take out the ovary for that. So if possible, I would completely agree that you should leave it and then rescan them, and you often find the cysts have disappeared anyway on the rescan 6 weeks later or whatever.
Yeah, so the timing of the follow-up, that's also, it should be stated, depends on the center. But for example, in our place, usually we wait 3 to 4 weeks, or we perform control ultrasound after menstruation. In case of functional cyst, of course, if there is a clear tumor, then it could be earlier. This is what I think about it, and also it depends. The first surgery depends on how prepared was the patient, because if it's a duty and you have no markers checked for example, in Poland, you can't perform a markers examination during the duty, only during the day. It's a hard situation for us, but we can't do this. So actually, we can't prepare the patient properly. And we always the TORS, and then we perform this second stage surgery. So it depends on how well you can prepare the patient for this surgery also.
Okay. Any other questions? I think we could take one more. Yeah.
Andrea Stolfa from Slovenia. I want to make a remark. I always listen that one of the signs that the torsion is there is absent blood flow. It's not true. It just means that you are too late. That's the only sign. And I never see blood flow. I always hope that there it is. And we always preserve ovaries. That's for over 20 years. But if there is no blood flow, it means that your diagnosis is too late. And we never make an MRI because it means that you spend the time that is vital for the ovary. So as soon as possible, do the deterquation.
Thank you very much.
I agree.
I actually have one question for the audience, if I may, and that is, I do quite a lot of fertility work as well, and it would be really interesting to know if any of you are planning to follow up these patients to see what their ovarian reserve is like when they reach adulthood, either by measuring their AMHs or their androfollicle counts. And I'd just be interested to hear if anybody's going to do that.